Hello everyone, welcome to the UNC Core Center for Clinical Research 101 Introductory Series for July 1st, 2020. We appreciate you joining us for today's talk. Our presenter today is Dr. Richard Loeser, who's the director of the Thurston Arthritis Research Center, TARC, here at UNC. His presentation today is titled Osteoarthritis Phenotyping 101. Whenever you're ready to begin, Dr. Loeser, feel free.
Okay, thanks a lot, and it's great to join everybody today. And thanks for the opportunity to talk about osteoarthritis. I think the majority of the people that are listening have a great familiarity with the importance of osteoarthritis, but for those that might watch the recording, just want to emphasize that this is the most common form of arthritis in the United States. With the aging of the baby boomers and the obesity epidemic, the number is expected to double over the next 20 years. Knee osteoarthritis receives a lot of the attention, and a lot of the phenotyping work that I'm going to talk about today is relative to knee OA, but there are some hand and hip studies that I'll mention. But knee OA is a big focus of research because about 85% of the global pain and disability of OA is related to knee OA. And then finally, the number of knee replacement surgeries in the United States has been on the rise. And a large reason for this is that we do not have any interventions for osteoarthritis that have actually been proven to slow the disease progression. So we have some treatments that are symptomatic and can improve function, but in terms of actually targeting the disease process, we don't have anything right now. And a lot of the drugs that have been tested that would be classified as disease-modifying osteoarthritis drugs or DMODs have failed in clinical trials. And as we'll discuss, one of the reasons may be because these drugs aren't being targeted to the right subgroup of people with osteoarthritis, and that's where phenotyping might play an important role. So what I'd like to address during the talk today is whether or not osteoarthritis is one disease or many diseases, and are there unique biomechanical, biological, structural osteoarthritis phenotypes? And then should intervention strategies be targeted to specific phenotypes? And then how do we discover and validate these particular phenotypes that we would like to use? So we know that there are a number of factors that are involved in the development of osteoarthritis, both systemic factors that are on the left and then biomechanical factors on the right. So things like aging, genetics, gender, obesity are all important risk factors for OA. And then biomechanical factors like malalignment of joints, particularly for knee OA, joint shape, which plays a particular role in hip OA, obesity, which is also a mechanical factor, and then joint injury. The tissue that I'm showing here is a slice of articular cartilage. This is normal articular cartilage with a nice smooth surface. This is early osteoarthritis where there's some loss of the articular surface and this fibrillation, matrix loss, and then you can also see thickening of the subchondral bone. And a lot of research has been done on the role of osteoarthritis, cartilage in osteoarthritis, but we know it's really a condition of the entire joint. So in addition to cartilage and bone, the meniscus is involved. And so with knee OA, meniscal damage seems to parallel the cartilage damage. Ligament tears are very common as well, such as ACL tears in knee OA. And not all of these are just post-traumatic tears, but many of these are degenerative tears that are seen in older adults. And then there's some degree of synovitis that seems to also be playing an important role in osteoarthritis. And all of these tissues, in addition to cartilage, produce a number of inflammatory mediators, cytokines, chemokines, various types of growth factors, and MMPs, which are matrix metalloproteinases, as well as factors made by the underlying bone. And all of these various factors contribute to the progressive joint tissue destruction that we have in osteoarthritis. So just looking at this slide, I think you can see what a complex condition osteoarthritis is, which makes for a heterogeneous condition based on the number of factors that are involved, both risk factors as well as joint tissues. It's worth, I think, taking a step back and looking at how you might define osteoarthritis. And this was part of an ORCE FDA initiative, coming up with a definition of OA. So just to go through this particular group put together a definition that osteoarthritis is a progressive disease of synovial joints, and it represents failed repair of joint damage. And this results from stresses, the biomechanical stresses that I just mentioned, and an abnormality of any of the joint tissues, cartilage, bone, ligaments, meniscus, and so on, as I was just showing in the previous slide. And ultimately, this results in breakdown of cartilage and bone, leading to the symptoms, pain, stiffness, disability, and abnormal intra-articular stress, and the failure to repair seems to be a result of all these factors: biomechanical, biochemical, and genetic. And then finally, this process can be localized to a single joint, a few joints, or generalized. And then they emphasized that the complexity and variability of OA, the etiology, suggests that there's a need for patient-specific etiology-based treatment. So again, this definition of OA really would suggest that there are more than one form of OA. It's multiple diseases rather than a single disease, and treating patients more based on etiology might be worthwhile. And this really brings us to the topic of precision medicine, which is something that is really being emphasized now in a number of different disease areas. Cancer is way, way in front of other conditions in terms of using a precision medicine approach based on factors such as the sequencing of tumors and looking at all the different intricacies of tumor types, and then coming up with specific treatments for specific tumor. But overall, what precision medicine is defined as, that these are treatments that are targeted to individual patients, and it's based on genetic, biomarker, phenotypic, or psychosocial characteristics that would distinguish a given patient from others with the same or similar conditions. And so this is sort of the goal of precision medicine. So for precision medicine to become a reality, we need to have a much better understanding of the various groups of patients that might be targeted for a specific therapy. So as I mentioned, we currently do not have any disease-modifying drugs for osteoarthritis. There have been a number of trials that have tried to look for disease modification that have all failed. And this is just a partial list of the trials. Bisphosphonate studies were done early on because in preclinical work, it was thought that slowing bone resorption might reduce disease progression in a way. Of course, glucosamine and chondroitin sulfate was touted as disease modifying and failed. Huge European study on blocking an enzyme called INOS, nitric oxide synthase, that was thought to be a pro-inflammatory mediator, failed. COX-2 inhibition, vitamin D, calcitonin, and many others. So one of the thoughts for these failures has been that perhaps the right subgroup of people with OA were not being targeted for specific treatment. And then another reason for the failure is that obviously everybody is lumped together for these trials. And what's normally done when you develop a clinical trial for OA, such as these, you take people that have, for knee OA, you take people that have knee pain, and then radiographic evidence of osteoarthritis based on plain films. And these are some images of the standard scoring system for knee OA that's used for these studies, called the Kellgren-Lawrence scale, which is 0 to 4. And these pictures show the grades 0, 1, 3, and 4. For clinical trials, most commonly, people with grade 2 or 3 are being entered. So grade 4 is usually excluded because that's end-stage disease, as shown here, where there's bone on bone. And grade 0, of course, is a normal joint. Grade 1 is a possible osteophyte that's shown here. So usually for the clinical trials, it's grade 2 or grade 3, which is shown here, along with knee pain. And then for the trials that are trying to look at whether or not a treatment is disease modifying, the outcome variable that's most commonly used is joint space narrowing. So you can see this narrowed space here, measuring over usually a 2-year period, whether or not there's a change in joint space narrowing has been a radiographic outcome. But the insensitivity of this method has been a real limiting factor, and we'll talk more about that. So one of the failed DMODE trials that I mentioned as an example here is the COSTAR study, which was a bisphosphonate called risedronate to slow bone resorption. And over 2,000 subjects were studied in a 2-year trial. And one of the outcome measures was a biomarker, CTX2. This is a biomarker of cartilage degradation, but it's also influenced by bone degradation as well. So the biomarker was decreased, but there was no change at all in the outcome of change in joint space width. And also no difference in the pain outcome, which was WOMAC pain, which is a common outcome measure for knee pain in OA studies. And the pain outcome is shown here. As I mentioned, change in joint space width is very insensitive as a measure. And then the other issue is not a lot of people in these clinical trials of 2 years actually have progression in terms of change in joint space width. And that's what's demonstrated here. So this is the placebo arm of the COSTAR study, looking at the baseline joint space width here, and then joint space width over 24 months, and whether there was progressive narrowing. And you can see that 71% of the people that entered the trial had no change whatsoever in their joint space width over 24 months. And only a small percentage, 2%, had the greatest decline of 2.1 millimeters, and then there are 2 groups with sort of minimal and moderate decline. So if this is your placebo arm and your intervention is trying to show a reduction in joint space width over 24 months or 2 years, and a very small number of people progress, well, then you're never going to be able to see that, even in a study that had over 2,000 individuals. They did try to look to see at who was more likely to progress in this trial, and that was the group that had less baseline joint space width, as you can see here, older and heavier individuals. But again, these are really not strong enough predictors that by themselves would help improve the trial much. So we'll discuss how phenotyping might be able to do this. So could phenotyping improve DMODE trials? This would be helpful by defining subgroups that might be more likely to respond to a specific intervention, such as a bone target, as I just showed. And as I just mentioned, predicting those are much more likely to progress. And then since treating OA at advanced stages is less likely to be effective than treating earlier stages, the other reason we're phenotyping, or the other area where phenotyping could be helpful, is detecting early disease, sometimes called pre-OA phenotypes, that would be more likely to progress. So now for some definitions of phenotyping that we should review. A phenotype is considered to be the composite observable characteristics or traits of an individual, and these traits result from both genetic as well as environmental factors. And so groups of patients that have similar observable characteristics are considered to represent a phenotype. And then another term that's often used in phenotyping is an endotype. And an endotype is a subtype of disease that's defined functionally and pathologically. So an endotype is where you understand a molecular mechanism or a treatment response that is recognized in a particular group of people. So identification of endotypes would be helpful to advance therapies that are targeted to a specific mechanism in the pathogenesis of OA. So the use of OA phenotyping and endotyping is needed for several different areas. Prescriptive phenotyping is the type of phenotyping that's used to select those who'd be more likely to benefit from an intervention, or identify those that might be more likely to have a serious side effect. Then there's the mechanistic phenotyping or endotypes that I just mentioned. These would be very useful for drug development and for targeted treatment. And then prognostic phenotypes. The prognostic phenotypes would be things like progression, and this could be used for treatment stratification, and also, again, to identify who might be treated in a particular trial. So in terms of coming up with particular phenotypes or subgroups in osteoarthritis, there are a whole host of different factors or manifestations that would need to be considered. And all of these are related to either risk factors for OA or things that occur as osteoarthritis develops and progresses. So genetics, joint overuse and gait mechanics, inflammation, hormonal factors, muscle strength, the number of joints affected, race and ethnicity, pain sensitization, and then the joint tissues affected, rate of progression, socioeconomic status, function, stage of disease, joint tissue metabolism, bone density, and then the presence of erosions or calcification. So you can see there are really a large number of variables that could be used for phenotyping. And as I'll try to demonstrate in some of the work that's been done so far, the more variables that you use, the better we're going to be able to define specific phenotypes in osteoarthritis. So the simplest way to phenotype OA might be based on etiological phenotypes, such as joint injury, which is often called post-traumatic OA, osteoarthritis associated with obesity, which is sometimes called metabolic OA, or specific genetic predispositions to OA, and then of course, aging, which is sometimes called a senescent phenotype, which plays a role in OA. But overall, these are much, much too simplistic to be useful for clinical trials, and I'll show some data to support that. These different predisposing factors, age, obesity, joint injury, joint shape, and genetics, really all lead to similar OA pathology at the end. So no matter what factors you have, the pathology seems to be similar in the advanced disease, which is shown on the right of the side of the slide. But what we're learning is that each of these predisposing factors, in some cases, may utilize a different pathway to get to OA. And in some cases, the pathways are in common. And I'll show you a demonstration of each of these. And this is important as we think about, targets for OA. So would the target for age-related OA be different than injury-induced OA, for example? So this is a study that our lab performed. Meredith Rowe was a PhD student. And this is a preclinical study in mice. And we were looking at a specific cytokine called macrophage migration inhibitory factor, or MIF. And this cytokine is involved in certain aging conditions, and it's been identified to be important in rheumatoid arthritis and lupus. So we looked at its role in OA. And when we looked at aging mice, 12-month-old mice and 22-month-old mice, comparing this as a score for cartilage damage, you can see a significant reduction in cartilage damage in the MIF knockouts, which are shown here, relative to the wild-type mice at both ages. And this is an osteophyte score. Again, significantly decreased in the MIF knockouts compared to the control. So it seemed that MIF was playing a role in in aging-induced osteoarthritis. But then when we looked at injury-induced OA, and this is taking younger mice and inducing osteoarthritis with something called destabilization of the medial meniscus, we basically did not see any effect at all of the MIF knockout. So again, this is a different cartilage score, SAPHO. These are the wild-type mice who had the surgery and the controls. These are the MIF knockout mice that had the surgery and the controls. You can see no difference at all in the MIF knockouts and the wild types, either in this score or in the osteophyte score. So in this case, MIF seems to be playing a role in age-related OA, but doesn't seem to have a role in injury-induced OA, at least in this model system. Contrast that with another preclinical study that was done by another group recently published with Nature Medicine, looking at aging. And in this particular study, they were using what's called senolytics. And senolytics are drugs or other mechanisms to kill senescent cells, because it's thought that senescent cells play an important role in OA. And in this particular study, it shows that they're important not only in age-related OA, but also injury-induced OA. So this is a different way of scoring the cartilage damage called the Archie grade. And these mice had surgery and ACL transection to induce OA. And basically, if you look at the surgical group here, you can see the control group compared to the senolytic treated group with this compound. There's a significant reduction in cartilage damage. And then they also looked at age-related OA using a different technique to kill senescent cells, which is shown over here. And again, a small number of mice, but there is a reduction in age-related OA. So at least in this case, senescent cells seem to be playing a role in both surgery-induced OA and age-related OA. So in contrast to the MIF study. So I think what we're finding is that these pathways to osteoarthritis are complex. In some cases, they're in common between two different ways of getting OA, and in other cases, they're different. There are other ways of defining OA phenotypes beyond just the simple risk factor identification. There's been a lot of interest in defining an inflammatory phenotype of osteoarthritis based on MRI synovitis or perhaps ultrasound synovitis and biomarkers of inflammation, because this group might be more likely to respond to an anti-inflammatory intervention. There are interest in defining specific pain phenotypes using things like the Pain Detect questionnaire and quantitative sensory testing. Multi-joint OA phenotypes may be important, defined by radiographs. Bone mass or bone-forming phenotypes, defined by DEXA, radiographs, MRI. And then others such as erosive hand OA phenotype, chondrocalcinosis, and malalignment phenotypes. So again, these are predefined phenotypes as opposed to letting the data define the phenotypes, but at least a way to get started. So this is an example of erosive osteoarthritis, and about 5% of hand OA is erosive OA. And if you look at this hand film, you can see there's destruction of the distal interphalangeal and the proximal interphalangeal joints with sort of this gull wing appearance. And this is from erosions that are central erosions, and then osteophytes and the other bony changes occur. So this form of osteoarthritis has been thought to be perhaps more inflammatory and might be more likely to respond to anti-inflammatory therapies. So we'll talk about a little of this when we get to some of the clinical trial data. So some early work to try to define phenotypes of osteoarthritis. This is from the Amsterdam cohort, where they had 551 people with knee OA. And the data they used for this study was leg strength, BMI, the KL grade, and then depressive mood. And then they used a cluster analysis called K-means clustering to try to cluster together people with different phenotypes. And basically, the clusters they found were pretty much driven by the data they collected. So they had a minimal joint disease phenotype, a strong muscle phenotype, based on the muscle strength, a severe radiographic OA phenotype, an obese phenotype based on the BMI, and then a depressive phenotype, based on the depression measure. So to me, this is not very helpful in terms of defining phenotypes, because it was really just driven by the data that they used for clustering. And of course, those data measures ended up in 5 different phenotype clusters. So there's been several different systematic reviews looking through the literature to see what phenotypes have been defined so far. And these include a chronic pain phenotype with central sensitization, inflammatory phenotype that I've mentioned already, metabolic syndrome phenotype, although there's a lot of debate whether or not OA is actually associated with the metabolic syndrome. It's clearly associated with obesity, but not all the features of metabolic syndrome. a bone and cartilage metabolism phenotype, the mechanical or malalignment phenotype, or a minimal disease phenotype. So these are what sort of had been defined prior to 2016. A lot of attention has been placed on using radiographic outcomes for phenotype, because obviously radiographs are available in patients with knee-OA and are used to clinically define knee-OA. So I'll go through a few of those studies. So this was work that used data from the Osteoarthritis Initiative to try to define subtypes of osteoarthritis. And they used data of the progression cohort, 518 individuals, and they combined both the plain radiographs as well as the MRI outcome measures, quantitative measures of thickness and volume and change in the bone, and some of the clinical measures, WOMAC, VAS pain scale, and demographics. And in this particular study, they used latent class cluster analysis to look for OA severity and cluster the patients or participants. And they wanted to look at those that progressed at 24 months based on both the KL score and joint space narrowing. And in this study, they described 4 different clusters. Those with mild OA were the most common, 47% of the individuals, and that was more on the medial side. Those in that cluster had a slightly higher BMI, which is a little surprising, but they had a neutral alignment and a low history of trauma. Then there was the classical OA group, about 20%, 27%, that had typical demographic factors. Then a low BMI group, but importantly, the low BMI group had lateral OA in that cluster, and they had a valgus alignment, which is associated with more severe lateral OA. And so that shows the strong effect of alignment. And then the 4th cluster was a group, the smallest group, 12%, which had more destruction and progression and also a higher history of trauma. Now, there has been some work in hip OA, and this particular study was phenotyping participants in a GWAS study. So this was a genetic study of over 2,000 individuals and 6,500 controls. And the idea was to combine a phenotyping approach using radiographs and the genetic results from the GWAS study. So they wanted to see if defining different hip OA phenotypes would help in the genetic analysis. So they looked at where in the hip was the maximal joint space narrowing, and then they had measures of bone remodeling response as shown there. And what they reported is that by using this method, it improved their precision of their genetic association analysis. So they found 6 single nucleotide polymorphisms that would have been missed if they just looked at the entire hip OA as a single group. So the stratification helped them identify additional genetic risk factors for OA. And they mentioned one particular one that's here, STTT3B, that we won't go into. Now going back to knee-OA, this is a study that wanted to look for people that had more rapid progression. And in this particular study, the rapid progression phenotype was defined as shown here as going from a KL 0 or 1 at baseline to a KL of 3 or 4, advanced or end-stage disease. And they used the most data set for this trial, where they had 262 progressors. And then they did a validation data set using OAI data, where they had over 2,000 individuals and 113 progressors. And the risk factors they found that were the most significant predictors of this rapid progression phenotype were individuals that had contralateral knee OA. They had an index knee, and then the contralateral knee OA, if it was involved, it increased the odds ratio by 2.76. The level of baseline KL in the index knee, so if it was 1, it was more likely to progress than 0. BMI, and then the WOMAC score. And they calculated an area under the curve for prediction of progressors and had a pretty good number, 0.79 for most and 0.81 for OAI, just based on these particular risk factors. And then this is a study from Tim McAlinden's group, again, using the OAI data set. And here they added in a bone density measurement as another variable. And so these were bone density measurements in OAI that were done by DEXA scan, where they measured the medial and the lateral bone density right here in the tibial area. So they used that as a way to see if that would improve the progression risk. And this was a cohort of 533 individuals. And this was between the 36 and 48th month visits of the OAI, where 14% of the people had progressed. And basically what they found was that for just baseline predictors, age, BMI, gender, recent injury, knee pain, and hand OA, all gave an area under the curve of 0.65 as risk of progression. But when they added in the BMD measure, and here they were looking at the ratio of medial to lateral BMD, they found they could improve the area under the curve to 0.73 with a significant p-value. So again, adding this bone density measure improved the ability to predict who was going to progress in this particular study. And then just a little bit more in terms of using MRI to define phenotypes in osteoarthritis. There has been consideration over the years that there may be what's sometimes determined as the atrophic phenotype. And basically the atrophic phenotype is shown here as someone who's got significant cartilage loss, but very little in terms of osteophyte formation. So there's hardly any osteophyte here. And you can contrast that to a hypertrophic phenotype where there's large osteophytes that are formed on the joint margin. And then there's a meniscal phenotype where there's evidence of meniscal damage that's shown in this image as well as in this image. And then an inflammatory phenotype. This is a large joint effusion, and this is Hoffa's synovitis, which is often used to define the inflammatory phenotype. So these are the proposed structural phenotypes that were based on MRI. And the MRI was looked at in this particular study. This came from the Osteoarthritis Biomarkers Consortiums supported by the NIH. And here they looked at the MRI features of cartilage, osteophytes, meniscus, the bone marrow lesions, as well as Hoffa synovitis and effusion synovitis that I showed you on the previous images. And they were looking at changes over 24 months that are associated with the radiographic and pain progression in the next 48 months. And what they found in this study was the best model for radiographic and pain progression was change in cartilage thickness and surface area, the effusion and Hoffa synovitis, and then the meniscal morphology. So again, showing the importance of these particular structures as predictors of at least radiographic progression and pain progression. So Phil Conahan, in this review, he proposed a way that imaging might be used to phenotype for intervention studies. So in this diagram, what he's showing is that individuals that have just isolated cartilage lesions and the rest of the joint's normal, perhaps they would respond better to manipulation of MSCs, mesenchymal stem cells, so trying to treat the cartilage lesion. Those with extensive synovitis might be more likely to respond to cytokine inhibition. And then those that had bone marrow lesions, maybe this is the group where the anti-resorptives would be more effective. And in fact, he's involved in one study that's scheduled to, I think, be completed in December called the COAST study, where they actually did use bone marrow lesions as the inclusion criteria for this study. And then they're looking at pain as an outcome along with change in bone marrow lesions using an oral bisphosphonate, an oral form of thylindronate. So we'll have to stay tuned for the result of that study. But there have been a few trials done so far that have tried to use imaging to include people for a specific intervention that unfortunately have not worked out so well. So these studies include a trial of an interleukin-1 inhibitor So this was a phase 2 trial of an inhibitor that blocks both IL-1 alpha and beta. And this was NEOA, where they included people that had synovitis based on MRs. But they found limited improvement in pain and no change in MR synovitis in this particular trial with the IL-1 intervention. And then 2 studies of erosive hand osteoarthritis, one of the same interleukin-1 inhibitor, and then one with a TNF inhibitor. And basically no improvement in pain, and in the IL-1 inhibition study, no change in imaging outcomes. And the same with the anti-TNF, no improvement in pain and very limited change in the imaging outcomes. So at least in these trials where there was some attempt to phenotype individuals, the trials still fail. Now, does this mean it's because the phenotyping wasn't good? Or what I think is probably more likely is that these just weren't the right targets. Because if you look at cytokines involved in OA, there's very little evidence that IL-1 and TNF-alpha are actually the key cytokines in OA. They play a more important role in other forms of arthritis like RA, but not in OA. So my interpretation of these studies is that it was the wrong target rather than the phenotyping didn't work. So what other data could be used to discover or better define phenotypes in addition to the demographic data and imaging data that I've talked a lot about? Whether there's interest in using genetics, transcriptomics, which is measuring RNA expression, and epigenetics in various joint tissues, metabolomics, and proteomics. In other words, a very big data approach to try to define phenotypes. And just a couple of examples of this. This is a study that was done using cartilage from NEOA and non-OA controls and using something called RNA sequencing, which is a way to look at the genes that are being expressed. And they found differentially expressed genes between the OA and the non-OA tissue. And then they applied this to the OA group, and they divided the OA group into 2 types. So there seemed to be 2 subtypes in this particular study based on gene expression, and then they validated it. So I'm not going to go through all the different genes that were differentially regulated between the 2 groups. But just basically to summarize, they found using RNA-seq 2 groups of people with osteoarthritis based on a differential in gene expression. MicroRNAs are an epigenetic regulator of gene expression, and these can be found in the circulation. And these are being used to try to define different people with osteoarthritis. Macrophages in the synovium. So this is a study that looked at synovial tissue from OA and compared it to inflammatory arthritis, finding that the inflammatory cells in the joint tissue might distinguish different groups of people with not only OA and inflammatory arthritis, but OA itself, and I'll show you that. But what's really striking here is if you compare OA synovial fluid to inflammatory arthritis, this is primarily RA, you can see a predominance of macrophages in OA relative to RA, which has a predominance of T cells. And when they looked at just the OA groups and sequenced the tissue from the OA groups, they found 2 different types of inflammatory macrophages, one that was more inflammatory-like and one that was more classical. So they found 2 subgroups of people with inflammation that was different between the 2 based on their macrophages. And then finally, as I mentioned, proteomics and metabolomics is being used. So this was a study, again, comparing 50 people per group of different types of arthritis, so rheumatoid, psoriatic, OA, arthritis associated with inflammatory bowel disease, and in healthy controls. And then they looked at specific urinary peptides to divide up each condition, and really pretty good area under the curve to define OA compared to the other groups of 0.9. And not that we need urinary proteomics to tell us who's got OA versus RA. That's not the point here. But it's that there may be a set of peptides that are more important in OA that could then be looked at further within an OA group. So as I mentioned, there is a lot of different data that could be used to define phenotypes. The examples I've shown you so far have used small amounts of data, but really not put everything together. But for the future, I think what the goal is to get as much data as possible, demographic data, comorbidities, injury history, and so on down the list. I talked about all of these early on. And then use bioinformatics, data processing, cluster analysis to start to group patients into subgroups, phenotypes, and endotypes. And then what's really important is to validate this data. So one example of this is work that Amanda Nelson from our group has done using a machine learning approach. And in this study, this used data from the FNIH Biomarkers Consortium, which is part of the Osteoarthritis Initiative, and data from 597 individuals. And here we looked at 73 different baseline variables. And the outcome measure that was of importance here was progression. And this was progression by both radiographs and pain. And using this machine learning approach, Amanda was able to assign what are called z-scores to the different outcome variables. And as shown down here, z-scores that are greater than 3 are considered to be statistically significant. So looking at all the variables together, of course, they were highly significantly predictive of the outcome when you included all variables. And whether they were in 1 or 2 clusters didn't seem to help any. The variables that were the most predictive were, as you might expect, the MR variables, quantitative as well as semi-quantitative, which are shown here, that have the highest z-scores. The demographic variables, so these would have been things like weight, age, so on, were not really helpful at all. And then the biochemical variables by themselves were also not helpful at all. So it was really the MRI variables that were best able to predict. But when you did look at all variables together, the ones that showed the greatest contribution to distinguishing progression included the imaging variables, the bone marrow lesions, osteophytes, medial meniscus extrusion, but then one of the biomarkers, urination. So again, this was a study that shows that combining a number of different baseline variables may be leading us into defining a progression phenotype. And of course, this needs to be further validated. So where do we go from here? Osteoarthritis phenotyping is really still in its infancy. We need studies having a larger number of phenotypic traits analyzed with state-of-the-art computational methods, better imaging and biochemical markers for disease progression, additional progressive prospective longitudinal studies, and then of course validation of the phenotypes is going to be very important. So most of the studies I showed you did not have validation cohorts. And then to judge whether or not the phenotyping has been successful, determining if targeting an intervention to specific phenotype will increase the number of responders and result in a successful disease-modifying drug that would slow disease progression. So all of these things are what I think we would like to be doing as we move forward. And just to mention, in terms of newer studies using larger numbers of phenotypic traits, there is an ongoing study in Europe called the Approach Study. And I have the website for the Approach Study up above if you want to get more information about it. Approach is the Applied Public-Private Research Enabling Osteoarthritis Clinical Headway. This is several different universities in the EU combined with several different companies that are putting money into this. Nordic Biosciences in terms of biomarkers, and GSK and Merck and a couple of other companies, because this is a very expensive study. And their goal is to describe, validate, predict NEOA phenotypes using clinical imaging and novel biochemical markers. And to do this, they are going to put together a cohort of 300 participants, and these are going to be pulled out from 5 existing cohorts. So their initial analysis is looking at thousands of people in these existing cohorts to try to determine what are the factors that are going to most likely predict the 300 who are going to experience progression over the next 2 years of the study. And then what they're going to do with those 300 is follow them for 2 years with measures at baseline, 6, 12, and 24 months. And they're gathering a large number of different variables demographic, physical exam, knee radiographs, hand radiographs, CT of the knee, but also whole body low-dose CT, which can be used for things like fat mass measures, MRI, the index knee, hand scan, which is a scan that they've developed that helps to measure inflammation in the hand, some motion analysis work, performance-based test, a bunch of different questionnaires for pain, function, quality of life. And then to go along with all this data, biological samples, blood and urine, that they're going to use for epigenetics, transcriptomics, proteomics, lipidomics, and metabolomics. So you can see it's not a large number of people, 300, but these are going to be 300 highly selected individuals. And then they're going to be really deeply phenotyped in terms of all of these different measures they're going to do, with the hope that they can find much better ways of predicting who's going to be progressing and who might be used in specific interventions. So that's something to watch out for. And we've talked to the approach group about some collaborations that we might be able to do between our group and theirs. So just to acknowledge people that helped contribute to what I talked about today. Meredith Rowe was a student who did the mouse study that I showed. The CCCR Phenotyping and Precision Medicine team has been fantastic to work with. I've learned so much from them, particularly Amanda, Steve Marin, and Michael Kozarok. Lee Callahan for her direction of the CCCR. And then Letitia Devisa is at the University of Sydney, and she's one of the people that contacted me early on to try to get some interest going in phenotyping in OA. And then, of course, our P30 grant that supports the CCCR, and then other grants that have supported my research. So with that, I'd like to end, and then I'm happy to take any questions, either through the chat box or if anybody wants to turn on their mics.
Yeah, so just to remind everybody to ask a question, type it in the chat box, or just unmute yourself, and then you can ask questions directly that way. Okay, it doesn't seem like it. So we can go in and wrap this up. So thank you, Dr. Loeser, for taking the time to talk with all of us today. I'm going to be sending a follow-up email to everybody in the coming days or within the next week with a link to access this recording of the talk in case you'd like to listen to it again or share it with your colleagues. Thanks again for attending the talk, everyone, and I hope everybody has a wonderful day.